Dr. Tony Tan. He still got some Chinese names, but I just know him as Tony Tan. So Tony, thank you very much.
Thank you, Prof. Michael, for the introduction. Thank you, Dr. Cristia, for the invitation as well. My first topic for the conference is elective vaginal delivery, the social indication, and as I understand from speaking to some of you, is that elective induction of labor in Philippines is hardly done. I'm just going to try and convince you that it's not such a bad idea actually. So social indications for elective vaginal delivery is increasing in Singapore. The patients love it, the doctors love it, the nurses love it. The patients love it because Singapore, there's 70% of Singaporeans are Chinese, and Chinese are very superstitious people, isn't it? So the Chinese will go to they will go to this religious leaders and they get special dates, even special times. I mean, I have been woken up at 5 a.m. to do a Caesar because the religious leaders say 5 a.m. on that day is a very good time. Similarly, there will be some requests that I want to be delivered on such and such a day, and if you don't induce them, they will want you to do a section for them. More and more, our patients are getting busier. They are traveling all over the world. The spouses are flying all over the country, and they are only free during this week. So they want to be delivered, induced on that week, so that you can, they can witness the birth of their child. We could have Indian parents living in Singapore, and when they said, induce my baby here, because I want my parents to come to India, and I want them to look after my baby's mother. So obstetricians are getting busy, and especially if your clinic is far away from the hospital, you would want to have a certain day where you induce most of your patients. I mean, when the obstetrician comes to Philippines for conferences, you'll want to induce them just before you come. Anesthetists are busy as well, especially in our setting where we have, our hospital does about 1,000 deliveries a year. So we don't have a stay-in anesthetist, and we have private anesthetists. And the anesthetists tend to be very busy. They are doing all kinds of cases, all in different hospitals. So if you can actually fix an appointment for them to come to do your elective epidural, it is quite ideal. However, of course, we recognize that there are problems of induction of labor. I mean, chiefly the main problem is failure of induction. When you induce a patient compared to spontaneous onset of labor, the patient, of course, spends more time in the hospital. If you induce a patient, the patient typically will feel more pain and typically will need more pain relief. And it has been published as well that there is an increased cesarean section rates when you compare them to those who go into spontaneous labor on their own. But this is a bit suspicious. Maybe we take a look at this in more detail. Is there really an increased cesarean section rate with induction of labor? All the older studies have been comparing cesarean section rates after induction of labor with the cesarean section rate after spontaneous onset of labor for the same number of weeks. So if I have patients who are induced at 38 weeks, I always compare them with those who go into spontaneous labor at 38 weeks. And then if I have those that induce at 39, I compare them to 38. That's not really fair, is it? Because that's not how it is done. If you induce a patient at 38 weeks, she will deliver at 38 weeks. But if you don't induce the patient at 38 weeks, she could deliver at 39, she could deliver at 40, 41, or even later. So actually it's fairer to compare the cesarean section rate of this group that you induce versus the group that are not induced at 38 weeks but go on to deliver spontaneously by induction or by cesarean section. If you compare this group versus this group, it will be a fairer comparison. When you are comparing induction versus expectant management. It may even be fairer to compare those that go into labor spontaneously at 38 weeks as well. 39, 40, 41, 42. So the older papers are showing that spontaneous onset of labor is lower, has a lower cesarean section rate compared to induction of labor. But the newer papers, when you analyze your data this way, is showing that actually the Caesar rate after induction of labor is either similar or actually slightly less. So let's compare elective induction of labor versus expectant management, meaning you watch and then you only induce if there is a medical indication. So there are two main papers on this. Stock had published in the BMJ 2012, it was a retrospective study. There were 1.3 million singleton pregnancies. It showed that induction of labor had an increased extended perinatal mortality rate. The cesarean section rates were not statistically significant, and in fact, in the induced group, they had less PPH and anal sphincter injury. So if you look at 37 weeks, with expectant management, the extended perinatal mortality rate was 0.24% compared to 0.09%. 38 weeks 0.21 compared to 0.08%, 39 weeks 0.18 to 0.06%, 0.16 to 0.08%, 0.16 to 0.07%. Clearly, induction of labor gives you better extended perinatal mortality. And it's a no-brainer because you're then going to reduce the stillbirths that are going to happen if you don't induce at 38 weeks. The stillbirths that, some of the stillbirths that may happen at 39, 40, 41 weeks. And the cesarean section rates, although slightly higher in the elective induction of labor group, but after they have looked at it with multivariate analysis, it was similar. Maternal complications with PPH at 37 weeks, less with induction at 38, 39, 40, 41, and also less anal sphincter injury when induced compared to expectant management. Corgi, who is from America, and he's a strong proponent of this. He looked at the data and he modeled the different strategies. If you induce them at 41 weeks versus expectant management from 41 to 42 and then you induce them, you're going to have less perinatal demise, less shoulder dystocia because your babies are smaller, less meconium aspiration syndrome because the babies have got less meconium, and less pre-eclampsia. If you bring this earlier, you induce them at 40 weeks compared to expectant management from 40 to 41 weeks, again less perinatal demise, less shoulder dystocia, less pre-eclampsia. And if you bring it forward to 39 weeks, again less perinatal demise, less pre-eclampsia. Here the shoulder dystocia is quite similar. So you see that the earlier you induce, you're going to have less of certain complications. What about maternal risk? Is there a difference between are there differences between the maternal risk according to when you deliver? And in this paper by Corgi again, it shows that the maternal and obstetric complications of pregnancy increases when your gestational age increases. So for example, if you have at 37 weeks your Caesar rate is 13%, 9.7%, and it increases all the way to 41 weeks at 23.5% and 31%. Clearly, as the gestational age increases, the Caesar for fetal distress increases. As the gestational age increases, the baby gets bigger, the Caesar rate for CPD increases. The rates of forceps and vacuum increases as the gestational age increases as well. If you look at third or fourth-degree tears, postpartum hemorrhage, chorioamnionitis, endomyometritis, and the long labor. You have the least rates at 37 weeks, and it increases slowly as you go up to 38, 39, 40, and 41 weeks. So if you just look at maternal age alone, maybe we should all induce patients at 37 weeks because it has got the least problem. However, we have to balance this with the fetal risk according to the gestational age. And if we just standardize our definitions, late preterm is when you are 34 to 36 plus 6. Early term is when you are 37 to 38 plus 6. And late term is when you are 39 to 41 plus 6. And I'm going to show you a series of data that shows that late term babies still do better than early term babies. And early term babies still do better than late preterm babies. So if you look at fetal risk, as the number of weeks increase, the passage of meconium increases, the IUD increases, the macrosomia rates increases, and however the NICU admissions is highest at about 37 weeks, drops a bit to 38, and actually is lowest at 39 weeks. And then it starts to go up again at 40 and 41 weeks. And actually 39 weeks, I'm going to show you later as well, 39 weeks seems to be the sweet spot. What about mortality data? In the past, people have been looking at neonatal mortality rates according to the gestational age, and the prospective stillbirth rates according to the gestational age. And where it crosses, they say that, hey, by 37 weeks, the chance that the baby is going to die from stillbirth is actually higher than the chance that the baby will die in the first month of being born. And so maybe we should all deliver our babies at 37 weeks. However, there are advantages even to infantile life of reaching a higher gestational age. If you look at infant mortality, actually at 37 weeks it is still significantly higher than 38, and 38 is still higher than 39, and at 39 this is where you get the minimum. So again, 39 weeks seems to be a sweet spot. How about acute morbidities? So if you look at death and or serious neurologic disorder, it's high at 34, 35, 36. It drops to 37, and from 37 it continues to drop at 38, and 39 and 41, 38, 39, 41 it seems to be. Morbidity, if you look at hospital stays more than 5 days, again it drops, 37, still drop to 38, and from 38 to 39, a little drop still. If you look at a composite measure of NICU admissions and respiratory problems, it drops. And again, lowest most at about 39 weeks. So you see that all the graphs show about the same kind of shape, isn't it? And this is looking at respiratory morbidity, where it is lowest most at about 38, 39 weeks. What about long-term outcomes? Are there, so what if 37 weeks, 38 weeks, they have just some short-term morbidity? Is it? It doesn't really matter, right? The long-term outcomes are similar. But no, the long-term outcomes are different as well. So if you look at cerebral palsy rates, it is lowest at about 40. Actually 39, 40, 41 is about the same. 0.1 to 0.11%. At 38 is slightly higher, and 37 almost double of 39 and 40. So what about IQ, mean IQ? If you deliver your babies at 39 weeks, it's about 106, and at 40 it's about 107. So every week it goes up about 1 point. Okay, so 1 point may be the difference between medical school and law school, isn't it? So that's important. So again, I draw another graph: cerebral palsy, developmental delay, cognitive dysfunction. lowest at about 38, 39, 40 weeks. The long-standing illnesses and wheezing at 39, 40 is still slightly better than 37 or 38. Social outcomes, and this is in the Scandinavian countries, we find that those that are born at 39 to 41 weeks tend to have the least disability, the least dependent on social welfare, the highest proportion of post-secondary education, and the highest proportion of employed. So it really, the timing of the delivery really tells us it's more than just short-term, it's also long-term outcomes. So is there a time for a change in the policy? Maybe we should only induce from 39 weeks onwards. So according to the American College of ONG, they recommend that there should not be any elective induction or cesarean sections to be performed before 39 weeks without any clinical evidence, indication or evidence of fetal lung maturity. And in JCI, I don't know whether here JCI is popular, but in Singapore JCI accreditation is popular. It is recommended to report all singleton deliveries at 37 or more completed weeks that are electively delivered before 39 completed weeks of gestation. So there is a push, especially from the American side, to reduce inductions before 39 weeks. And in this paper, it showed that the only way you can effectively reduce that is to have a policy that does not allow inductions, social inductions before 39 weeks. Okay, so that's my two babies, and true to form, they are delivered at about 40 weeks. Not induced, but we went into spontaneous labor, and this was all before the data was out, and hopefully we have that 107 IQ. And maybe next thing, so we have, looking at all the data, we know that if you induce patients at 39 weeks, it seems like you're going to get the best outcomes. I'm just going to introduce this concept of active management of risk in pregnancy at term. We call it ARMOR, EPAT, active management of risk in pregnancy at term. Again, it is popularized by Nicholson, who works with Augie. And in the first paper, they looked at 100 women who are managed according to this active management versus 300 who are managed with standard management, and these are of mixed parity. In the active management group, 63% were induced and 26% on the standard management were induced. But you look at the Caesar rates, 4% versus 17%. So despite a higher induction of labor rate, the Caesar rate was actually lower. And in a later paper, where they did a randomized control trial, again the Caesar rate was lower, although the numbers were small, so it didn't reach statistical significance. So it's 10 versus 15%. And again, if you induce them actively, the admission to ICU is 1.5 to versus 6.7%. So what do they use to look at the risk? Basically, they look at what is the chance that this pregnant woman, if she goes into labor, what's the chance that there is uterine placenta insufficiency? And what's the chance that this person will have CPD? And then they determine what is the optimal time of delivery, and then they deliver them before they reach the optimal time of delivery. So using their own population, they have their own odds ratio, and these are the different odds ratio they have for the different risk factors of the patient developing uterine placenta insufficiency and the patient developing cephalopelvic disproportion. Of course, I don't use this, and you shouldn't use this as well, because these odds ratio are specific for their own population. If you have your own specific odds ratio, you can then use this to predict. But basically what they use is, if you have any of these risk factors, this is the number, the time limits, and they take 41 weeks minus the total of this time to develop the upper limit of the optimal time of delivery. And they score it for A, they score it for B, and they take the lower of the two. So they always deliver, the time that they are going to induce is always more than or equal to 38 weeks, and it will be less than 41 weeks. So for different patients, they have a different risk. And using this, they go on to study for nulliparous women as well as multiparous women, and again you get the same results. High induction rate, low seizure rate. Low seizure rate. So it's very clear that it works. Of course, the model, everybody will have to use your own model to determine. Well, what do? I use my own model. Similarly, I assess the risk of uterine placenta insufficiency and CPD. I look at the mother's height. The mother is less than 1.5. That's short, isn't it? My patients, I see them, especially in the third trimester, I see them every 2 weeks. I measure the HC, AC, and FL. I look at the deepest vertical tube, and I identify those who have inadequate growth velocity. I also identify those who are big. In the Asian population, we take 3.6 kilos, and in the Caucasian population, we take 4 kilos. And all my patients, I do serial Doppler studies. I look at the umbilical artery as well as the MCA. If the UAPI is more than 95th centile or the MCAPI is less than 5th centile, that's bad. Typically, in the uncomplicated patient, these are normal. What's more significant, I think, is the MCAPI to UAPI ratio, which is the cerebral-placenta ratio. This is probably a more sensitive marker for uteroplacenta insufficiency. And if it's less than 5th centile, we tend to want to induce them at 37 to 38. And on top of that, I also assess the favorability of the cervix. Weekly, from 38 weeks onwards, I check the vagina examination. And if it is cervix is favorable or not favorable. Well, if it is favorable, I will discuss with the patient, and then we offer cervical membrane stripping from 38 weeks onwards. Well, if the cervix is already more than 3 centimeters and soft and stretchable, I try not to, because I've done a few. I've stretched them in the morning and afternoon, they come into labor or come in the night and totally destroy my dinner plans. And then I plan for prostate. If the cervix is favorable, I will plan for prostate. I discuss with the patient and I'll plan for prostate at 39 weeks plus. And if it's cervix favorable, 1 prostate at 6 a.m. Cervix not favorable, and if I'm inducing them for medical reasons, I will plan for 2 prostates, one at 12 midnight and another one at 6 o'clock midnight. Avoid the second pastry if she's already having regular painful contractions. Okay, I arrange for, so I tell my anesthetist ahead of time, and by the way, some of you may know that my anesthetist is my wife, so I try not to disturb her before 8 and not too early or not in the middle. So 8 to 10, and we fix an appointment, and she comes at about 8 to 10, where the patient is still not having too much pain. We do a vagina examination at 12, and we start oxytocin if the contractions are not more than 2 yet. And we will rupture the membranes when it's more than 4 cm. And we aim to deliver them by about 5 to 7. And it works pretty well, and I think using this, we will achieve vaginal delivery in at least 90%. Ideally, the best patient to induce will be those who actually ask for planned delivery, and they want a planned epidural as well. These are the best people to induce. Whether nulliparous or multiparous, as long as they have a favorable cervix, they become easy to induce. They must not have any previous seizures or myomectomies. And if you have been showing reassuring ultrasound surveillance, no evidence of placenta previa or vasa previa, scophalic presentation, good growth, normal Doppler studies, and should be at least 39 weeks because you want to induce responsibly. If cervix is not favorable, I will wait. And for us in Singapore, most of us will induce by 40 plus 3. So when to induce for those with complications during pregnancy? Now, in these scenarios, there are a little bit more data. So the Habitat trial, they have shown that if you induce at 37 weeks, you get slightly better maternal outcome. In the Habitat 2, they're going to look at inducing them between 34 to 37 weeks. In GDM, they have shown that if you induce them at term, you get less macrosomia. And in twin timing of birth, they have shown again that if you induce them at 37 weeks, you have less serious adverse outcome for the infant. And there's going to be this trial called the 35-39 trial, where women, because they have shown that women who are 40 years and above have a similar stillbirth risk at 39 weeks as women who are between 25 to 29 years old have at 41 weeks, sorry. So they're trying to see if all 35 years old women should be induced at 39 weeks. Actually, I think whatever your age, you should be induced at 39 weeks. Especially if your cervix is bigger. Small babies, again, if you induce or you wait, it doesn't seem to make much of a difference. So I finished my review of induction of labor for social indications. Actually, it's not so social anymore. There's a lot of medical advantages when you induce them without widely accepted medication. And I'd like to invite all of you to this 9th Singapore International